Hello and welcome everyone. My name is Matt Shepard and I'll be moderating today's session, Understanding the Changes in Medicare Part D for 2025, presented in partnership with the PAN Foundation. Our presenters today are Center for Medicare Advocacy Co-Director David Lipschutz and PAN Foundation Chief Mission Officer Amy Niles. Before we hear more about those two great organizations, please bear with me while I do a little housekeeping for us all. As with any online presentation these days, audio and video connectivity are going to be at the whim of the internet. But if you have audio trouble at least, please note that in the audio section of the control panel you should see at the right of your screen, you can switch to calling in by phone. It's old school, but it's a stable connection. Should anyone have trouble watching, also note that all of our registrants are going to receive a link to the recorded presentation after the fact once it has processed. For the bulk of today's live presentation, we're going to keep this massive group of attendees, thank you all for turning out, muted. So we certainly won't get to everyone's questions when we do Q&A. But please do note that we have a questions section of the control panel, and you should see that at the right of your screen as well. And in that section, you can type your questions, and I'll do my best to relay those to our presenters. We also have the traditional chat section they may be used to from Zoom and Teams and all those other programs. I'll monitor the live questions, the questions panel, and my cohort, Jeff, will keep an eye on that chat for us. In addition to both of those, we received literally hundreds of questions and comments during the registration process. And I know that our presenters today are going to try to address some of the common themes from those as well. Speaking of those presenters, a little bit more about the organizations they represent. First, the Center for Medicare Advocacy. Center for Medicare Advocacy is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy, all based on the experiences of the real people who contact the center every day. For the PAN Foundation, I'd like to bring up and introduce Amy Niles, Chief Mission Officer for the PAN Foundation, to tell us a little more about them. Amy.
Thank you so much. I am honored to be beside the Center for Medicare Advocacy today to talk about some important changes coming to the Medicare program. The PAN Foundation is a national charitable foundation and healthcare organization, and our mission is to accelerate access to affordable, equitable healthcare. We do that through what I call our three pillars. The first is providing financial assistance to people who are underinsured to help them afford their out-of-pocket treatment costs. We do that through more than 80 different programs at the PAN Foundation, and we're here to support people who are living with serious illness, cancer, chronic diseases, and rare diseases. Our grant amounts are covering copays, deductibles, coinsurance, premium insurance, as well as transportation assistance. Our second pillar is advocacy. We have long advocated for patient-centric policy solutions to improve access to care. And our third pillar is education, educating patients, healthcare providers, other organizations about a range of issues relating to navigating a very complex healthcare system. So happy to be with you today.
Thanks so much, Amy. And now we'll bring David Lipschutz up and we'll start our presentation in earnest. You'll hear a little bit more from Amy later.
Thank you, Matt. Thank you, Amy, and thank you to all of you for attending today. This is an agenda of what we plan to go over the next hour. I'm going to kick us off by providing an overview of big picture changes to the Medicare Part D prescription drug benefit pursuant to the Inflation Reduction Act. Then Amy will focus on two of the biggest provisions of the IRA, the $2,000 out-of-pocket cap and the prescription payment program that allows people to spread their costs over the calendar year. And then I will come back in on part 3 and talk about other provisions of the Inflation Reduction Act aimed at trying to reduce the costs of prescription drugs, including drug price negotiations and premiums, including a recently announced demonstration meant to keep premium increases down. Then Amy will end by talking about various ways to get assistance with drug costs, and then, time permitting, we will engage in question and answer. As Matt noted, a number of folks did send in questions ahead of time, and we will try to address many of those during the course of the presentation. So, starting with part one, the overview. This slide provides a snapshot of the Medicare program, parts A, B, C, and D. It's also meant to convey the fact that prescription drugs are covered in all parts of Medicare, but are subject to different costs, different rules, and different issues that apply to each setting. Part A covers drugs in the hospital, skilled nursing facility, to a limited extent in the home through the home health benefit, and under the hospice benefit covers drugs for palliative care. Part B of Medicare covers drugs that are usually not self-administered, and that's typically drugs you have to go somewhere like a doctor's office or outpatient clinic to receive, chemotherapy being a notable example. Part C of Medicare, also known as Medicare Advantage, is the private plan option. People enroll their Medicare into private HMOs or PPOs usually, and get their Medicare coverage exclusively through that plan. Medicare Advantage plans are required to cover everything that's covered under parts A and B. So that means they cover all the drugs that are supposed to be covered under parts A and B. In addition, most Medicare Advantage plans also offer Part D prescription drug coverage, and Medicare Advantage plans that do so are called Medicare Advantage Prescription Drug Plans, or MAPDs. And then, of course, we have the Part D prescription drug benefit that's only available through private plans, either a standalone prescription drug plan, or PDP, for folks in traditional Medicare, or through a Medicare Advantage plan that offers prescription drug coverage known as a Medicare Advantage Prescription Drug Plan. Today, we are talking almost exclusively about changes that have been made to the Part D prescription drug benefit, and those changes apply to both standalone Part D prescription drug plans and Medicare Advantage prescription drug plans. Note that Part B covered drugs will make a brief appearance when we talk about ways that the drug law is holding costs down, including with respect to annual increases in the costs of drugs and with respect to drug price negotiation. So a brief history of the Part D benefit helps put the changes we are talking about today in perspective. For many years, there was limited coverage in Medicare for prescription drugs outside of those Part A care settings or those drugs covered under Part B. In order to address the shortfall, Congress passed the Medicare Modernization Act in 2003, which provided for prescription drug coverage starting in 2006, available only through private plans. Again, the standalone Part D prescription drug plans or Medicare Advantage plans that offer prescription drug coverage. The Medicare Modernization Act created a structure of Part D benefit that in many ways did not previously exist in nature. There was a deductible and then an initial coverage phase during which people had to pay a certain percentage of their drug costs. But then if people reached an additional stage called the donut hole, their coverage would drop altogether and they would be uncovered unless and until they reached drug expenses that attained a higher threshold, at which point they still had to pay 5% of the cost of their drugs, regardless of how high those costs went. The Medicare Modernization Act also created the Low Income Subsidy, or LIS, also known as Extra Help, to assist with drug costs, about which Amy will talk a little bit more later. The dreaded donut hole, the gap in coverage, was not well understood, nor was it well liked, and created a real gap in coverage for folks and access to care problems. So Congress made subsequent reforms that closed that donut hole. The Affordable Care Act gradually phased in the donut hole, planned to be closed by 2020, and the Bipartisan Budget Act of 2018 accelerated that closure by 1 year till 2019. But even with the closure of the donut hole, there still remained what's known as a coverage gap after an initial coverage phase. It's a period of time which The beneficiary is responsible for 25% of the cost of drugs or the equivalent, but behind the scenes, because of the different amounts of costs that Part D plans and drug manufacturers were responsible for, it changed how quickly someone would move through that coverage phase to get to that catastrophic coverage, and could alter the amount of costs that beneficiaries were paying for individual drugs. And it was harder to monitor where you were in that structure, in that scenario. That'll all be clear in a couple slides. The Inflation Reduction Act of 2022 was one of the biggest changes to the Medicare program since its inception, and was aimed with its prescription drug provisions at saving both beneficiaries and the Medicare program money by lowering the costs paid for prescription drugs. It is these changes pursuant to the IRA, or Inflation Reduction Act, that we're primarily discussing today. It brings beneficiary and programmatic costs down. The Congressional Budget Office, for example, estimated that taken together, the drug pricing provisions in the law will reduce the federal deficit by $237 billion over 10 years. At the same time, while the IRA is lowering drug costs for Medicare beneficiaries and the Medicare program itself, Part D plan sponsors are taking on additional liabilities for high drug costs, which is mitigated somewhat by other changes in how risk is apportioned in the Medicare program. So let's take a quick overview, a look at the overview of the major prescription drug related provisions of the Inflation Reduction Act, which are being implemented over time, each one about which we will discuss further. The Inflation Reduction Act allows Medicare to negotiate with drug manufacturers for the prices of certain Part B and Part D drugs. As Amy will discuss in a few moments, it caps beneficiary out-of-pocket expenses for Part D drugs at $2,000, and also, starting next year, allows beneficiary costs to be spread out over the calendar year. The IRA imposes checks on the annual rise in costs of drugs and Part D premiums. Starting last year, it limits or caps monthly copays for insulin and eliminates cost sharing for a number of vaccines. And starting last year, expands eligibility for the Part D low-income subsidy. And essentially, people who were eligible for a partial benefit before are now eligible for the full benefit. So here's a quick timeline of the implementation of these changes. And you'll be seeing this slide again soon when we talk about drug price negotiation. Briefly, as we'll talk about in the next slide, in 2023, insulin copays were capped and certain vaccines became cost-free for beneficiaries. This year, an out-of-pocket cap has actually been instituted. And right now, it's at roughly $3,300 a year, depending upon the mix of brand or generic drugs that you take, a precursor to lowering that overall cap to $2,000 in just a few short months. Also, that change in the low-income subsidy is effective this year, and starting in 2026, we start to see the results of drug price negotiation. So let's start with the provisions that were effective last year, namely the insulin copay cap and vaccines. Beneficiaries with diabetes who use insulin covered under Part D are subject to a $35 per month out-of-pocket cap for the cost of those drugs, for the insulin. Insulin also can be covered under Part B when used with an external insulin pump. These prices are not subject to the deductible. Now, there are certain rules that Part D plans have to follow with respect to what they cover in a formulary. They broadly have to cover 2 drugs per category and class of drug, and must cover substantially all of 6 protected classes of drugs. That means that they don't cover generally all drugs in a given category or class, including insulin. So Part D plans do vary in terms of the insulin products that they cover. And this protection applies to the particular insulin products that a particular Part D plan covers. For all the insulin that a Part D plan covers, is subject to this $35 out-of-pocket cap. So it pays to shop around if you require a particular type of insulin. Also effective last year, cost sharing was eliminated for a number of adult vaccines covered under Part D. Now, some vaccines are covered under Part D, some vaccines are covered under Part B. Many of the Part B covered vaccines were already free at no cost. Others require a coinsurance. This provision of the Inflation Reduction Act covers most Part D covered vaccines that are recommended by the Advisory Committee on Immunization Practices. Most notably, that includes the shingles vaccine, of great interest to beneficiaries. So the IRA also restructures what the Part D benefit looks like. This is what the Part D benefit structure will look like in just a few short months. Note that the donut hole had already been eliminated, but also the confusing coverage gap that worked behind the scenes and the corresponding out-of-pocket threshold and when that threshold would be met will no longer be around. The benefit is much more straightforward with 3 levels. There's a deductible, which for a basic benefit will be $590 per year in 2025. There's an initial coverage limit during which beneficiaries are projected to pay 25% of the costs of their overall drugs. And if you reach that $2,000 limit, including the deductible, then you hit that out-of-pocket cap that Amy will talk more about. But for now, note that that cap does not include premiums, does not include drugs that are not covered under Part D, and does not include drugs that are not covered under your Part D plan unless you successfully appeal to have them covered. Also note that this chart displays the standard benefit, what is required under the law. Since the start of the Part D prescription drug benefit, plan sponsors have had the option to offer enhanced or alternative plans that use a structure of cost sharing that is more favorable for enrollees. For example, it could include a lower or no deductible, or a reduction in cost sharing or coverage of drugs that are not usually covered under Part D. And in fact, most plans today are non-standard plans. So most plans in 2025 are not likely to look exactly like this. There might be a lower deductible. The 25% coinsurance might look different based upon what tier of cost sharing plans choose to apply to drugs or copay amounts. And instead, that amount is likely to vary by coinsurance or copayment. So I'm now going to hand it off to Amy to talk about the out-of-pocket cap and the prescription drug payment program.
Thank you, David. And we are very excited about these 2 reforms that are coming January 1st because they are good for patients. David, you did a great job summarizing the Medicare reforms that started to get implemented in 2023, vaccines without copays, insulin copays limited to $35 a month. So I won't go into that in any more detail. This year we saw, as you indicated, 2 really important reforms get implemented. One was the expansion of the Extra Help program. So today, people who have income up to 150% of the federal poverty level can benefit from the full benefits, which means that they're going to pay very little, if anything at all, for their out-of-pocket costs for their prescription medications. What's important to note here is that we all need to do a better job of educating people about this program. It's estimated that there are at least 3 million people in the United States who are eligible for Extra Help, but are not aware of the program. The second reform that went into effect this year was the elimination of the 5% coinsurance for catastrophic phase. And this is really important, especially for individuals who are living with very serious illnesses, cancer, chronic diseases, rare diseases. We help them every single day at the PAN Foundation. Prior to 2024, many patients experience very high out-of-pocket costs, $5,000, $10,000 or more in out-of-pocket costs. So the elimination of the 5% brought that out-of-pocket burden down to between $3,300 and $3,800 this year, which is still a lot of money for a lot of people, but it's a step in the right direction. And we're really excited about what's to come in just a matter of a few months. Next slide. And those 2 reforms is the Medicare Part D cap, which we'll review, and the Medicare Prescription Payment Plan. The Medicare Prescription Payment Plan, we at PAN commonly referred to as smoothing. In fact, we pioneered the conversation around smoothing more than a decade ago because we see firsthand every year what patients go through when their deductible is reset and they're faced with sometimes thousands of dollars in out-of-pocket costs in January or February alone. Next slide. So I'm going to review in detail both of these reforms, starting with the Medicare Part D cap. This is a hard cap or limit of $2,000 in out-of-pocket costs for people with Medicare Part D coverage starting January 1. And all drugs that are included in the Medicare Part D program are covered under this cap. This cap will help everyone, but in particular, it will help the individuals I just spoke about. The individuals who have historically faced very high out-of-pocket costs because they have expensive medications to treat very serious illnesses. What do patients need to do to benefit from the Part D cap? Nothing. This cap is automatic. There's no eligibility requirements, no income requirements. It will go into effect automatically for people with Medicare Part D. And how will patients pay for their medications? They will continue to pay for their medications just like they do today at the pharmacy counter, unless they opt into the Medicare Prescription Payment Plan. Next slide. So the Medicare Prescription Payment Plan goes into effect January 1, 2025. By law, included in the Inflation Reduction Act, all plan sponsors must offer, and this is for standalone Part D plans and Medicare Advantage Part D plans, they must offer the opportunity to their enrollees, the opportunity to opt in to this payment plan called the Medicare Prescription Payment Plan. And when they do so, the enrollee will be able to spread their payments out over the calendar year. Generally speaking, it will benefit the individual to opt into this program prior to the plan year, for example, in the upcoming open enrollment period, or at the very beginning of the plan year, so that someone has more months to spread their costs over. The Medicare Prescription Payment Plan is a wonderful program, but it will benefit certain people much more than others. So for example, if an individual has historically incurred very high out-of-pocket costs, for example, $2,000 over the first 9 months of the year, this program may be beneficial for them. If they have incurred a one-time prescription fill of $600 or more, this program may be beneficial for them. If they don't want to pay all of their costs upfront in one lump sum, but they want to budget better, which will make them afford their costs better over the calendar year, this plan may be beneficial for them. But for someone who is at up to 150% of the federal poverty level who may be eligible for the extra help program is really a better option than opting into the Medicare Prescription Payment Plan. Similarly, if an individual can get a grant from a foundation like the PAN Foundation to cover out-of-pocket costs, that option might be more beneficial than the Medicare Prescription Payment Plan. How can patients opt into this voluntary program? And that is very important. Unlike the Medicare Part D cap, which is automatic, people will need to take action to opt into this program, and they will do so directly with their Part D plan. They will either call their plan to enroll in the program, or they will visit their Part D plan website, where there will be information about the Medicare Prescription Payment Plan and instructions on how to opt in. What will patients' costs look like month to month? This is going to be different for every patient depending on their circumstances. The costs are going to vary likely from 1 month to the next, depending on when the patient is filling new prescriptions or perhaps going to the pharmacy to refill. So there's variability, and it may be hard to predict what someone's cost will be next month. What we do know is that by the time they get to the end of the year, they will not have spent more than $2,000 because of that Medicare Part D cap. So I'm going to give a very simple example, and I preface that by saying simple because this can get a little bit complicated for individuals in terms of calculating truly whether this option for them is a good one or not. So let's say Mary opts in at the beginning of the year, and how Part D plans are going to calculate their costs will be what Mary would have paid for her prescriptions, plus any previous month's balance, divided by remaining months in the year. So again, a simple example. She didn't have any costs in January, but in February, she faced a large cost of $1,030. So how the plan is going to calculate that is they're going to take that $1,030, add her previous balance, which was 0 in January. So that's $1,030. And we're going to divide that by 11 months, which includes February. And that comes up to a monthly cost of $94. But based on the situation and how these costs vary from month to month, for some patients, this is a great option. For others, they may find that their costs will increase at the end of the year, and perhaps will not be a good option for them. How will patients pay for their prescription medications? This is a behavioral change that's going to be very important because they're not paying at the pharmacy counter. If someone opts into the Medicare Prescription Payment Plan, their plan is going to give them a bill every single month indicating what they owe and the date by which they need to pay. So now that enrollee is going to receive 2 bills from the plan. One is for their premium, and one is for their prescription medications. It is advised that if there is a challenge affording both, that individuals focus on paying for their premium because they don't want to lose their Part D coverage. And what if payments are missed? And this will happen. Life happens, people get sick. If that individual does not pay by the due date on the bill, they'll get a reminder from their Part D plan. But if it's not paid within 2 months, that plan may kick the individual off of the Medicare Prescription Payment Plan. Not the Part D plan itself, but the payment option. If there's any outstanding balance, that individual will need to pay that outstanding balance. They can do it all at once or monthly. And once they have reconciled those costs, they can opt into the payment plan again if they wish to do so. But they need to reconcile their outstanding balance. Additionally, if they opt in and they determine that they no longer want to participate in this plan, they can leave the payment plan. Again, they need to pay any outstanding balances. And once they leave the Medicare Prescription Payment Plan, they will return to paying for their prescription medications at the pharmacy counter. So for a reform that we all thought would be a little bit more simple, it's actually a little bit complicated, especially behind the scenes. So I think all of us have a lot to do to educate both patients and providers about the Medicare Prescription Payment Plan. Next slide, please. So I've just here provided a quick overview of how the Medicare Part D cap and the payment plan differ. So does the reform lower prescription medication costs? Well, the Medicare Part D cap does. It's a hard limit of $2,000, and this will be, as I mentioned previously, particularly helpful for people who are used to paying much higher costs. The Medicare Prescription Payment Plan does not lower costs, but it makes them more affordable for many who are looking to spread those costs out throughout the calendar year. And again, generally speaking, the more months one has to spread those costs, the more affordable they will be. Who is eligible? Well, anyone with a Part D plan, either through traditional Medicare or Medicare Advantage, will benefit from the cap. And in terms of the payment plan, it will be offered to all enrollees in Part D plans. What do patients need to do to benefit? Nothing for the cap, it is automatic, but for the payment plan, patients, individuals will need to do something. It is a voluntary program. They will opt in through their Part D plan, either by calling the plan or going to their website. And how will patients pay for prescription medications with the Part D cap? It will be at the pharmacy counter, but as we talked about, unless they have opted into the payment plan, they will pay their Part D plan directly. Next slide. About a couple of months ago, we fielded a national poll of Medicare beneficiaries to determine how aware Medicare beneficiaries in general were across the country, how aware they were of the Medicare Part D cap and the Medicare Prescription Payment Plan. The full results of the poll we will release in a matter of a few weeks when we launch our own Medicare Reforms national campaign, but I just wanted to share a few key findings from the poll with you today. Next slide. So, not to my surprise and perhaps not to your surprise, there was very low awareness about both of these reforms. Some of that is understandable because we know it's just now when a lot of information is being disseminated by Medicare, CMS, SHIP counselors, and so on. Next slide. What we found in our findings is that, again, it's not a surprise to the PAN Foundation. We hear this every single day. 1 out of every Medicare beneficiaries are taking action to better afford their prescription medications because the costs have been so high. And toward the bottom of the slide, you see the majority of Medicare beneficiaries have not heard about the Medicare Part D cap or the Medicare Prescription Payment Plan. And that second bullet is important because many beneficiaries are worried about the unintended consequences of some of these reforms. As David alluded to, the Part D plans have increased financial liability under this program. So there's concern that they may take some action to prevent access to needed medications by patients. Next slide. So won't go into all the details, just to say very few are aware of the Medicare Part D cap. When we explained the Part D cap to them, they understood it, but they needed a little bit more explanation. But the majority believe that with the Medicare Part D cap, it's going to be helpful to them. And this was especially seen amongst individuals living with disabilities and people of color. Next slide. Similarly, with the Medicare Prescription Payment Plan, and probably more so than the CAP, extremely low awareness of the payment plan. When the payment plan was described to the Medicare beneficiaries, some understanding of it, but as we've just heard, this payment plan can be a little bit complicated to explain. Nevertheless, just like the CAP, they think it will be helpful to them. That fourth bullet points to the need to really educate about the Medicare Prescription Payment Plan and the Extra Help program. And the message there is, if one is eligible for Extra Help, that really may be a better option for someone as opposed to the Prescription Payment Plan. And today, if asked, 1/3 of Medicare beneficiaries polled said that they would likely enroll in the Medicare Prescription Payment Plan. That may be a perfectly reasonable number, as we described. It may not be for everyone. It just may not be a good program for someone, for example, who has low out-of-pocket costs or who wants to pay their costs all upfront. Next slide. And so some key takeaways from the poll for us is that there is an information gap that I know all of us are working toward to fill, from CMS to Medicare, Center for Medicare Advocacy, and the PAN Foundation, and many other organizations and groups. We found that 3 in 4 Medicare beneficiaries are interested in learning more. They did have a greater awareness of the Part D cap over the payment plan. As I mentioned, a real opportunity for all of us to come together to educate beneficiaries about the benefits of both of these reforms and to explain the nuances between Extra Help and the payment plan. Next slide. And we can go one more slide. So at the PAN Foundation, we are committed to educating the community around these Medicare reforms. Once the IRA passed, we created a Medicare Reforms Education Hub at our website, which is panfoundation.org. The information that is currently there is going to be updated over the next 2 weeks to describe in more detail the Part D cap and Medicare Prescription Payment Plan. And importantly, those resources will be both in English and Spanish. But we are creating some additional resources, including educational booklets and animated video explainers, also in English and Spanish. I'm going to be participating in a radio media tour on October 16th, one day after open enrollment, in an effort to educate communities across the country about these 2 reforms and how the Part D program is changing. And similar to what we are doing here today, participating in other educational webinars, including our own webinar in mid-November to educate patients and healthcare providers about the important reforms. Next slide. Here are some resources that we always want to disseminate to webinar listeners, patients, healthcare providers: Medicare.gov, our own education hub at panfoundation.org. The State Health Insurance Assistance Program is a really important program for individuals to receive free personalized insurance counseling, and that website is shiphelp.org. And of course, learning more about the Extra Help program at the website you see here today. Next slide. And I will turn it back over to David.
Thanks, Amy. So in this next section, I'm going to take a quick look at other efforts pursuant to the Inflation Reduction Act to try to keep the cost of prescription drugs down. In addition to the out-of-pocket cap, there are other provisions such as drug price negotiation, efforts to keep premiums down, and we'll also provide a couple of miscellaneous items, including addressing Part D creditable coverage or creditable coverage in relation to Part D, along with a few practical tips for shopping for Part D plans. One of the most impactful and at the same time controversial from the standpoint of some stakeholders, namely pharmaceutical manufacturers, is the provision that allows the Secretary of Health and Human Services for the first time in the history of the Medicare program to negotiate for the costs of certain high-cost drugs covered by Medicare. Note that the authority is not there to negotiate any drug. The scope is actually quite limited. It's limited to single source brand name drugs or biological products without essentially real competition, without competitors, and have been on the market for at least a number of years. The first 10 drugs were selected by Medicare last year, and the negotiated prices will be effective in 2026. We'll talk about in a minute. This drug price negotiation process will continue in future years with an additional 15 drugs negotiated in 2027, another 15 in 2028, and then an additional 20 drugs in each year thereafter. Note that it's starting off with Part D covered drugs, but Part B covered drugs will also be subject to negotiation effective starting 2028. Now, for this part, I am speaking only for the Center for Medicare Advocacy when I say that our organization has been strongly supportive of this provision, granting the Secretary the authority to negotiate prescription drugs. But the pharmaceutical industry, the Chamber of Commerce, and others have challenged this provision in various courts across the country. And so far, courts continue to reject these challenges. And we, the Center for Medicare Advocacy, have been proud to participate in some of the amicus briefs submitted to courts to help the government defend this provision. There are forces that wish to repeal this provision, namely in some cases the entire Inflation Reduction Act, but to do so would require an act of Congress and would be at a cost to the government because the projected savings would go away. I'm showing this slide again just to demonstrate that the drug price negotiation process happens over time. Next year, we'll see the process start for a second batch of drugs with prices effective in 2027. Note that that number of drugs increases and will accumulate over time. The first 10 drugs, the negotiated prices effective in 2026, a little over a year from now, were announced a little over a month ago. I won't go over those individual drugs. They are available at these links here. According to the Department of Health and Human Services, the negotiated prices on these drugs range from 38 to 79% discount off of list prices, with a projected savings to the Medicare program of $6 billion in 2026, plus $1.5 billion in out-of-pocket savings for beneficiaries in 2026. A couple of weeks ago, Reuters published a report finding that for these specific drugs, the drugs are still on average more than double, and in some cases 5 times what drug makers have agreed to in 4 other high-income countries, which is a way of saying this is going to really help, but there is potentially a lot more savings available. Now, I want to touch on a couple of other, in addition to drug price negotiations and out-of-pocket cap for beneficiaries, a couple of other provisions of the IRA that are aimed at keeping down the costs for the Medicare program and beneficiaries. One of those requires drug companies to pay rebates to the Medicare program if drug prices rise faster than inflation. This applies to certain drugs and biologicals covered under Part B and Part D. Note that these are rebates paid to the federal government, not to beneficiaries, but beneficiaries will benefit by, in turn, having lower cost sharing or co-insurance for the drugs that are subject to this provision. The Senate Finance Committee just released an analysis of the impact that this provision has had on Part B drugs since January of last year, estimating that there have been $3 billion in savings for beneficiaries and taxpayers on approximately 98 different Part B drugs that have been subject to this provision. Another provision of the IRA that aims to try to keep costs down has to do with premiums. It's known as premium stabilization. We're going to talk more about this one and Part D premiums in general next. Let's start with a quick discussion of Part D premiums in general. We don't yet know what the actual 2025 Part D premiums will be. We're going to find out soon in just a couple weeks, probably likely just before October 1, when the plans can begin to market their products for 2025. For now, let's look at 2024. The weighted average premium for the standalone Part D prescription drug plans is $43 this year, weighted by enrollment. But most people in Medicare Advantage plans don't pay any premium for their drug coverage. Due to a number of factors, subject for another day, Medicare Advantage plans are paid on average more than traditional Medicare spends on a given beneficiary, resulting in significant overpayments to Medicare Advantage plans, some of which they use to buy down things like the Part D premium. So most people in MA plans, about 3/4 of all Medicare Advantage prescription drug plan enrollees don't pay any premiums for Part D coverage, while more than half of all standalone Part D prescription drug enrollees pay $30 or more monthly premiums. Also note that higher income individuals pay a higher amount for Part D, regardless of what the individual plan premium is. It's an income-related monthly adjusted amount that also applies for the Part B premium. And note that if someone is eligible for Part D, in other words, they have Part A and or Part B, which triggers their eligibility for Part D, they are expected to enroll in a Part D plan unless they have what's known as creditable coverage that we'll discuss more in a moment. So while lowering the costs for beneficiaries, the Inflation Reduction Act does change some of the financial obligations for plan sponsors, manufacturers, and the Medicare program itself. Because of these consumer protections, such as the out-of-pocket cap, there was a concern that plans could significantly increase premiums in order to offset some of these expenses. In order to protect against this, there is a provision of the Inflation Reduction Act that caps growth in Medicare, in Part D premiums rather, to no more than 6% per year. But that applies across the board and not to individual plans. It only applies to the basic benefit. And remember, most plans are enhanced. They offer something more and in return, charge an extra premium amount in addition to the basic one. This also applies to both prescription drug plans, standalone plans, and Medicare Advantage prescription drug plans. And as noted, most Medicare Advantage plans use their extra rebate dollars to lower or eliminate the Part D premium to zero. So we're looking at an average rate across the board where Medicare Advantage plans by and large don't charge premiums. There's a lot more room for standalone Part D prescription drug plans to charge a much higher amount, way above the 6%, because it is all averaged out. And concerns about increased premiums for 2025 were borne out when the Medicare program received the proposals or bids back from the Part D plans when they presented what they planned to offer for next year. Many more standalone Part D plans indicated that they would charge increased premiums. So in response, the Centers for Medicare and Medicaid Services used its demonstration authority to try to keep premiums low and announced a voluntary demonstration to stabilize the standalone PDP market in the initial years of these significant changes going on with the Inflation Reduction Act. It's assumed that most plans are participating, but we won't yet know for sure until the plans and plan benefits are announced in a couple weeks. And those plans that participate in this demonstration will have their ability to increase premiums limited in exchange for some extra protection if people reach that catastrophic level of coverage. A quick note about creditable coverage. People who have coverage other than Part D that's considered at least as good as what you can get under Part D have what's known as creditable coverage. The providers of other type of prescription drug coverage have to notify people with such coverage every year as to whether or not their prescription drug coverage remains creditable. Because the Part D benefit is getting better, namely it's going to have this $2,000 out-of-pocket cap, there was some concern that maybe some drug coverage that was better than Part D will no longer be better than Part D because Part D will cap its expenses at $2,000. Now, it's not a direct apples to apples comparison. It doesn't mean that if you have other prescription drug coverage and it doesn't cap drugs at $2,000, then by default, it's not creditable anymore. It's a more nuanced assessment. For now, we have no information as to the extent to which any plans will be considered no longer creditable, but it's one more thing that merits increased attention for beneficiaries to pay attention to, and those of you who assist beneficiaries to look at. So just a little bit of practical tips for the upcoming annual enrollment period that begins on October 15th. Use the Medicare Plan Finder to compare plan options. As Amy suggested, use the SHIP program, the State Health Insurance Assistance Program Network, sometimes called something different in your state. Every person currently in a Part D or Medicare Advantage plan will be receiving an annual notice of change that outlines how their coverage is changing for the next year. Pay particularly close attention to that ANOC notice when it comes this year. And a bit of advice, never shop by premium alone, whether it's a Medicare Advantage plan or Part D prescription plan. And while having an out-of-pocket cap will make it easier to compare plans, don't just go by the premium. There are other factors that people need to weigh, including what drugs are on the plan's formulary, what barriers the plans put in the way towards accessing such drugs, utilization management, and what things such as what pharmacies participate with the plan. Similar to Amy, I'm leaving you with a few resources directly from the Centers for Medicare and Medicaid Services and Department of Health and Human Services. KFF, formerly known as the Kaiser Family Foundation, also has excellent tools that summarize these provisions of the Inflation Reduction Act. With that, I will turn it back to Amy to close us out talking about assistance with drug costs. Amy.
Great, thank you, David. And before I jump into that, I just want to comment on the premium conversation, because we've been concerned and we've actually been hearing from many patients that we serve that they're concerned that premiums are going to rise. And so back in early March of this year, through PAN's Center for Patient Research, we actually did a poll of Medicare beneficiaries around premiums. And what we found was that 1/3 of beneficiaries enrolled in Part D plans saw higher premiums in 2024 than 2023. And of those beneficiaries who reported increases, 11% said that their premiums increased between 16 and 20%, and 10% said that the premiums rose greater than 20%. 40% of the beneficiaries said that they're having a hard time affording their premiums. So this is something that I think we all need to watch. I alluded to, potential other unintended consequences of the IRA and Medicare reforms. And so we're going to continue to monitor to see if we are finding that there's an increase, for example, in prior authorizations, an increase in the use of step therapy, or if there's formulary changes that are happening, really preventing access to care. So I just wanted to comment on that before I turn to financial resources for prescription medications. I speak a lot with patients and healthcare provider groups and other organizations, and I often come to the conclusion that there's unfortunately very low awareness that there are wonderful resources out there for individuals to help them pay for their out-of-pocket costs. Of course, we have the pharmaceutical manufacturer assistance programs who are primarily there to help people who are uninsured or people who are commercially insured. Pharmaceutical PAP programs cannot help individuals with federal insurance, and that's why the safety net that foundations like the PAN Foundation provide is so important. We talked about the Extra Help program. We did a similar poll that we did with premiums around the Extra Help program, and unfortunately, half of the individuals, half of the Medicare beneficiaries we polled did not know anything about the Extra Help program. Charitable patient assistance programs, we are one of about 9 foundations who do similar work in terms of providing assistance for copays, coinsurance, and deductibles. Collectively, We provide about 200 different programs to help people afford their medications. At PAN Foundation specifically, over the last 2 decades, and we're celebrating our 20th year anniversary this year, we have helped more than 1.2 million individuals, and we've provided more than $4 billion in financial assistance. And while a very large number, we know that there's many more people that we need to be helping. So Fund Finder that you see at the bottom of the slide is a web app that we launched about 5 years ago because we knew it was very challenging for patients and healthcare providers, patient navigators, et cetera, to know what foundations existed, who provided what, and what grant assistance was available. So by registering for Fund Finder, which you can do very easily at fundfinder.org, you can see in one place all the programs that these 9 foundations offer. And if you choose to follow any particular disease that you might be interested in, you will get alerts when grant assistance is available. So it's an important resource for all of you to know about. Next slide. And I know we're running short on time, but all of you are likely familiar with other resources that are available, including the state pharmaceutical assistance programs, Medicare savings programs, and the AIDS drug assistance program. Next slide. Just a high-level overview, and we can go one more slide about assistance at PAN. I mentioned we have more than 80 different programs that support individuals living with life-threatening chronic and rare diseases. This is a list of all of our programs that we offer today. We have a very long list of additional programs that we are ready to open because we know that there is need, but we need funding to do that. But right now, any individual or healthcare provider can go onto our website, look at our eligibility criteria. If funding is available, that individual can be enrolled in a program in the matter of minutes, and they can take their PAN insurance ID number to the pharmacy counter and start accessing their medications without any costs. Next slide. And finally, we already talked about Fund Finder. We have a growing network of more than 100,000 users for this web app. We know it is a tremendous time saver for people looking for charitable assistance, especially if one is a Medicare beneficiary. And so I encourage all of you to spread the word about this very worthwhile program. Next slide. I'll turn it back over to you, David.
Thank you, Amy. We know that there's a lot of information. We do have a hard stop at the top of the hour. We have just a couple minutes for questions. I don't know if Matt and Jeff, you've been able to synthesize any questions into overarching couple of questions we might be able to address.
There are a lot of questions, and there are some themes here in the questions. Several questions on the Plan Finder. When's the Plan Finder get updated? Will the Plan Finder be able to tell us costs if we're in the payment plan program?
So I'll take the first part, Amy, if you can take the second part. The Plan Finder, in theory, should be updated for 2025 as of October 1st, and it should have a function that allows you to compare plans for the remaining portion of 2024 and separately for 2025. Sometimes state health insurance assistance programs might have a slightly earlier access, but sometime around October 1st is when we anticipate that information to be posted.
And I believe Plan Finder will have some sort of what I call a wizard to help provide guidance in terms of the Medicare prescription payment plan. What I'm not sure is how much granularity there will be around the wizard and whether an individual will be able to actually, for example, input all of their costs and actually compute what their monthly cost would be for the calendar year.
All right, thank you both for that. We also had lots of questions on the potential premium increases. And interestingly, right as you were discussing shopping by premium, David, a couple people asked, but wait, isn't shopping by premium sensible if you can find a plan with all your drugs on the formulary because you know you got this $2,000 cap now?
In theory, yes. I think that principle is most applicable to Medigap plans, Medicare supplemental insurance plans, because those plans are standardized. You know exactly what you're going to get from one plan to another, but there is considerable variation among Part D plans. They can have different formularies. They can have broader formularies, more narrow formularies. They can employ different levels of utilization management tools. Like Amy was talking about prior authorization or step therapy. They can have, a broader range of pharmacies or a narrower range of pharmacies. So there is more than just a premium to pay attention to when shopping for plans. It should make it easier, but we're urging folks to take another step in their analysis.
Thanks, David. And thank you, Amy. I know you have to depart for another event. We really appreciate your joining us today for this incredible turnout and fantastic information. On that note, everyone, we will be resending the slides, and we'll also be sending a link to the recorded presentation if anyone got in late or those people who couldn't get in, and we'll have that out and posted by tomorrow at the latest. I want to thank you all again, and thanks once again to the PAN Foundation for their partnership on today's presentation. And check our website for information on our upcoming Medicare Open Enrollment Updates webinar in October. Registration is now open, and we expect another big crowd. Any plugs from you, Amy?
No, it's just wonderful to be with all of you today. Have so admired the work of the Center for Medicare Advocacy. So honored to partner with you and to provide really important information for Medicare beneficiaries. So thank you.
Thanks, Mark.
Thank you so much. Thank you, Amy and David. And I will now conclude today's presentation.